And now we will move on to the discussion session. We will have, well, probably only about 20 minutes for discussion. Meaning we must finish by 11:50 to go back to Hall 1 for the conference wrap-up. Yes, it will take about 15 minutes for Dr. C to summarize briefly. Yes, I invite the esteemed delegates. Does anyone have any questions? Yes. So I would like to ask Dr. Bai a little, if I recall correctly, in the respiratory technical procedures we are developing this time, is there a technical procedure for split night studies, right? Pressure titration is definitely included, but is the split night study included yet? No, we haven't had another council meeting yet. The council will meet again in the upcoming round. Now they require us to state how many cases we have performed. We must state how many cases we have performed and build the pricing based on that. Right, so, if we have never performed any cases before, and if we haven't done them, they require us to get those parameters from another hospital, but it must be a public hospital, not a private hospital or clinic. Right, so we are very stuck because we don't have the equipment. Regarding equipment, currently, first of all, we don't have a titration machine. We don't have a CPAP machine for patient ventilation in the hospital. The machines currently in the department are just CPAP machines, or BiPAP machines, or those large BiPAP machines. As for the machines with full titration modes, we currently don't have them.
Not yet.
Yes. Secondly, for the titration system, for instance, PSG or cameras and such, we also have to rely on CPAP's support. Therefore, even for things like ETCO2 monitoring, we don't have them, so it's very difficult. If I do one case, I have to ask the company for help, meaning it has to be a very special case to ask, not just any case. So I don't think we should include this in the catalog, because even the input, the standards required to perform it, are already insufficient. In the immediate future, we will finalize the technical procedures within the Ministry of Health's upcoming changes.
Yes.
Regarding the next steps, once the technical procedures are established, they will require us to run a pilot program before health insurance will accept them. It is a pity that Mr. Hoang's facility has done a lot of work but it hasn't been recognized. Phuoy Viet facility was not recognized. We have to calculate technical norms and list all the costs and expenses to include them in the proposal.
Perhaps next time we can consult with Dr. C and Dr. V, and ask for their help and the association's support on how to include it. Ms. Han's point is indeed correct. It is the upcoming trend. To report to Ms. Han, firstly, for any work, including sleep labs covered by insurance, the Ministry of Health Council is now asking for a 6-month certificate. Therefore, we need personnel. For example, at Bach Mai, Tam An is doing well, because they have already studied and received the 6-month group certificate. Besides that, there are other supporting certificates, so they require, first, certification, and second, equipment. And third, as Ms. Han said, prepare the procedures before we invest in and purchase the equipment. Regarding private facilities that have been reimbursed, for example, some hospitals only cover PSG, so the association will make a proposal. Currently, there are only Phuoy Viet in your facility. Additionally, the Sleep F location is also a training site for the association, so there could be 3 locations to start proposing costs and conditions for titration, as well as the patient selection process. Therefore, Ms. Han's idea is correct. Let's just prepare the procedures first. Second, we must have equipment because depreciation is calculated based on how much we invest in order for insurance to cover it. Third, the personnel are already available and have completed their training. So, the remaining parts are just the procedures and purchasing equipment. Without the equipment, we cannot implement it. Therefore, we should propose that the center invest in these things, as they are very important. In reality, the center is the place that needs to cover all types of respiratory diseases, including chronic obstructive pulmonary disease, obesity, and alveolar hypoventilation. Thus, following Ms. Han's opinion, I would note that if we don't have it yet for now, we shouldn't try to borrow machines, as it often goes against the principles. We should send them to other locations, for instance, to C or SM, to establish a calibration room, and then we can coordinate, acting as the ones who perform the calibration there. Moving equipment in and out is hard to bill for and is also difficult, depending on the long-term situation. In Ho Chi Minh City, we already have Phoi Viet. In the Central Highlands region, there is the Professor's Place, which already has TCO2 and everything else. Therefore, the most important part is which patients need titration, like in the master's presentation. We must ask if these patients get over 6 hours of sleep at night. Sometimes they wake up, but they are able to fall back asleep, because after 3 hours, if we attach the mask, they often cannot fall asleep. We need to exclude patients with insomnia. Thus, the most important thing is the calibration night. Often, if the patient cannot sleep, it is very costly and ineffective, even regarding the AHI index. Therefore, the current trend is to have devices that track AHI indices over 3 days, 2 weeks, and provide reports. I would like to tell Ms. Han that I recently reviewed a study from the US involving 50,000 people. They used a device placed under the mattress to monitor sleep apnea over a year, yielding over 1 million results, and they found that it was 80% accurate based on the average indices assessed over many days and months. Because when you do the titration on that specific night, and the next night other factors come into play, including REM sleep, as Dr. Ba mentioned, we often find that we treat the earlier part while we were measuring, but it turns out the earlier part was milder than the later part. In the latter part of the night for older adults, there is more REM sleep and more apnea. Therefore, it is difficult, and we might have to re-evaluate after 3 months if the treatment does not show a response. Ms.
The BMI is over 40, and the AHI is over 40. Those are the criteria, but besides those, could there be other criteria to select patients more accurately? Because while split-night sleep studies can be more economical, we might conversely miss cases where REM sleep occurs in the later part of the night, right? Another issue is the task of convincing patients to use CPAP or NIV, which is extremely difficult. I must say, it is extremely difficult. In clinical practice, there are patients who say, "Oh, I feel very uncomfortable, I cannot tolerate it." Secondly, they ask, "What if I stop breathing during the night?" Meaning, if I wear the machine, what if I stop breathing in the middle of the night? For example, in such cases, based on Dr. Ku's experience, how do you usually explain it to convince patients to use the CPAP machine? To be honest, in private hospitals, there is still time, but in public hospitals, doctors examine dozens of patients a day, especially at Bach Mai, so you know from experience that with 5 to 6 patients, there is no time to sit and convince them. At Tam An, I could sit and persuade 20 or 25 patients a day, but that number is starting to rise now. So, for example, besides what Ku has presented, do you have any further experience? In this regard, and for these things, for instance, especially with CBTA, we also need to have specific procedures. C will probably have to bring that up in the future. The current problem is that the Ministry of Health and Health Insurance still do not recognize the role of associations. Meanwhile, in other countries, whatever associations put forward is usually accepted. But here, health insurance insists on everything going through the Ministry of Health. However, the Ministry of Health is gradually beginning to accept things if we build clear procedures and guidelines, and then it can be transferred to insurance. This is where the role of the association presidents is definitely very important. Yes, thank you for your question, Ms. Han. Regarding my experience, in a study I am currently conducting under Professor Sis guidance, I enrolled about 102 patients. Initially, they agreed verbally to join the study and agreed to CPAP. The entry criteria were patients who agreed to CPAP. After subsequent tests, only 69 patients actually used CPAP. This means that even with our study's best efforts to follow up, it was only about 70. That is about 70 patients who, following their initial promise, actually agreed to use CPAP. Then, another 30 to 40% dropped out in terms of continued CPAP use. Some patients even went as far as buying the CPAP machine but still did not use it. And to manage that kind of follow-up, fortunately at the University Medical Center, I have the benefit of the sleep study lab, which gives us time to counsel patients. It operates independently from the clinical department, acting like a subclinical unit where we can provide counseling to patients afterward. But the issue remains monitoring the patient, meaning, after the patient has purchased the CPAP and so on, the patient often doesn't contact the doctor again. If, for one, the patient decides not to buy it anymore, changes their mind, or undergoes end surgery, etc., they also don't get in touch and don't return for follow-ups. And even if the patient buys the machine, some still don't contact us for follow-ups, so it becomes the technician's role to monitor the device. So, what can we do? I feel it's very difficult in a public hospital environment, whereas private clinics have more time, and patients really need that follow-up. Truthfully, we also lack a procedure for patient follow-up after they buy the machine, like when to return for a checkup, or when to follow up after 1 or 2 weeks. And patients will slowly drop off after that. Especially when the initial period of using the machine is uncomfortable, it's very difficult. Honestly, if I were to use CPAP for OSA patients, it would only be for about 5 cases that I would really need to use it, to the extent that I would have to follow the step-by-step process I presented earlier. Otherwise, there are cases where it's already full, or it's hard for the patient to continue halfway through, or simply because our current processes don't allow for enough time. Regarding the CPAP, there will be more detailed procedures, and perhaps the association can assist with providing training.
Yes. Thank you, Ms. Han, and thank you for the response from Master DM Ku. Truly, the issue of CPAP treatment, for doctors who are knowledgeable and have studied it, is very easy. Prescribing it is very easy. And especially, patients also know about the treatment issue. The hardest part in Vietnam, truthfully, Ms. Han, is not the issue of compliance. It is related to the financial means to purchase it. But honestly, once understood and guided, if testing reveals different therapeutic methods, we must clearly state there are 7 or 8, such as weight loss, sleeping on the side, and even cases where CPAP is used while still being advised to lose weight. Those are the cases that were recently examined and consulted at 199 here in Da Nang, and we have implemented it that way. Because there are cases that require a lot of time to lose weight, especially in young people, we still advise parallel CPAP therapy and weight loss. After 3 to 5 years, they might stop CPAP, alongside other methods. Therefore, regarding CBT, we have CBTI, CBTO for OSA, and CBTC for COM-ISA, which can potentially replace medication by over 50% if used for chronic insomnia. CBTO is a supportive method for treatment alongside CPAP. Or, if CPAP is not available due to various conditions, it also serves as a therapeutic option. In it, we integrate all perceptions regarding behavior, including sleep habits, sleep hygiene, and some other aspects, such as compliance, which we must address in parallel, will also be integrated. And in this part, the association will develop the procedures and training content. It is expected that each CBTI will consist of 10 sessions, 5 for theory and 5 for practice. CBTO will follow similarly, and then CBTC will be added. CBTC for COM-ISA is like integrating all the contents of both insomnia and sleep apnea treatment. This is very important, because in that process, we integrate all the tasks related to CPAP treatment compliance, which we must do before these parts. Therefore, or in very severe cases, we perform them in parallel, and that is how it becomes a procedure. Regarding how we monitor patients and the specific skills required, while this has become routine practice at places like Bạch Mai or Phoi Viet, many other doctors are not yet familiar with it, so we will focus on this in the near future. And finally, regarding obesity hypoventilation syndrome and obstructive sleep apnea, please pay close attention to that area. For treatment with ventilation or CPAP in severe cases, especially in titration scenarios, we need to continue to develop those capabilities. Hopefully, by next year, TAM-AN will be ready, or even if they start sooner, We can refer patients there for titration instead of taking on too much, as each technique is different. If we have the resources, we should perform them at our own facilities. This will create a network with specialized centers, community-based care, and even more advanced specialized units. I believe we have about 2 minutes left before we finish. So, for the remaining time, I would like to address the professors and the speakers, as well as Ms. Han. Well, thank you to Master Hu Hoang, and Dr. Thị Ba, Master Diem Ku, and especially Ms. Han for your very insightful questions and the feedback shared by our speakers. This is excellent content that could potentially be presented again at future seminars or workshops. Finally, I would like to thank Ms. Han, Vice President of the Vietnam Respiratory Society. Thank you to all the professors and speakers. I invite you all to move to the auditorium. Bottom 1 for the closing ceremony. Thank you.